So we will be having just a few introductions and announcements before we get started. Our discussion today will be by Dr. Alfaro Cruz on perinatal hepatitis C and linkage to care. We will have a couple of case presentations and an opportunity for questions and at the end, and then of course, just some closing reminders. As always, if you have not already registered with the Southeast AIDS Education and Training Center, please do so. You can do that by utilizing the QR code in the slide, or you can also use the link. This ensures that you get your continuing education credit. You will be emailed a post-session survey, and then your certificate will be emailed to you at a later date. But you must attend the full session in order to get credit. So as always, just a few reminders. We do have a new person today for our tech support. If you do have any issues during today's session, please reach out to Allie. She can drop her contact information in the chat. She is filling in for Kimber today. But also, please feel free to drop your name, your organization, and your title in the chat as well. In addition to if this is your first echo session. All right, so I see a couple of people have done that. I appreciate it. And Allie has also included her information as well. Her email is allison.phillips@tn.gov. Again, please reach out to her if you do have technical issues for this particular session today. All right, we'll go ahead and move forward. And Dr. Alfaro Cruz, I will hand it over to you.
Hi, can you guys listen to me?
Yes, we can hear you.
Sorry, I had a little bit of it disconnect me. Okay, so good afternoon, everyone. My name is Dr. Alfaro Cruz. I'm a pediatric gastroenterologist located at East Tennessee with East Tennessee University. I will talk today about perinatal Hep C and the linkage to care. Next slide, please. So I have no financial disclosures or conflicts of interest to report. Next slide, please. So let's start by stating the definitions of perinatal Hep C. So this is the transmissions of the hepatitis C virus from an infected mother to her baby during her pregnancy or childbirth. We know because of the studies that we have so far in the United States, the vertical Hep C transmission, it's close to 7.2%, but it tends to increase to 12.1% for women who are co-infected with HIV. And this is what the latest studies have report regarding the incidence of vertical transmission. Next slide, please. So as you can see here, this is information that we have from the state of Tennessee from 2018. We're not seeing a significant increase over the last couple of years, but just to give you an idea, the population that is most commonly affected is non-Hispanic white women, followed by non-Hispanic Black, Hispanic, and then other population, including Asians or mixed population. So far, the rate of non-Hispanic white women that have actually been infected with Hep C virus is close to 22.7 per 1,000 live birth. Next slide, please. This map shows you with the state of Tennessee, and as I'm not able to point out, but if we look at it from the east portion of the state where I actually work and live, That is where we tend to have the most exposure rate of perinatal hepatitis C. This actually goes hand in hand where these are the areas that are usually more affected by the use of IV drugs or IV drug abuse, with increase in the use of fentanyl, cocaine, heroin. So we do see a correlation among the maps between of those. Next slide, please. So far, and talking a little bit before going into details with the infants. So right now, these are the different recommendations that we have regarding the screening during pregnancy with Hep C. From the CDC, usually they recommend Hep C screening to all pregnant women during each pregnancy. Also, as we know, the United States Preventive Service Task Force recommends screening for all adults between age 18 to 79, including pregnant women, at least once a year or with every pregnancy, especially in those high risk populations. And the American Association for the Study of the Liver Disease, Infectious Disease Society of America, they do recommend that as part of prenatal care, all pregnant women should be tested for Hep C infection with each pregnancy, ideally at the initial visit where they start their prenatal care. Now, there has been some discussion about those women that may have some risk or risk behavior factors that can increase the risk of them getting infected with Hep C. And in those cases, sometimes they have even recommended retesting at the end of the pregnancy or when actually they are coming to actually give birth. Next slide, please. So, what are the screening methods that we're using in pregnancy? So, as we said, screening should be done through serological detection of antibodies, followed by a nucleic acid test or an PCR, RNA PCR, in patients who have a positive anti-Hep C screen. Now, it's important to know that those women that in the past have had a Hep C infection, their antibody is always going to be positive. So, those are the cases where it's recommended to do a Hep C PCR RNA to make sure there is no inactive infection. Screening is usually often done at the early prenatal visit, along with screening of other infectious diseases, especially hepatitis B and HIV infection. There is, as we were talking a little bit earlier about, those who have increased risk factors for Hep C, a follow-up test can be considered later in pregnancy or at the time they're admitted to the hospital to give birth, especially those who have had uh, identify or test positive for substance drug abuse or that have been in jail as more common factors. Next slide, please. So, what are the factors that are associated with Hep C perinatal transmission? So, we know about the maternal Hep C RNA levels. And so, in general, some studies have suggested that a higher maternal Hep C viral load will correlate with an increased risk of perinatal transmission. But we have to be honest about this because there is not a precise viral threshold that will say if you have above this, that would actually increase the risk to mother to child Hep C transmission. So we don't have enough studies that kind of correlate that. We know that co-infection with HIV for sure, and multiple studies have shown that women that have Hep C viremia and that are co-infected with HIV, they do have an increased risk of perinatal transmission. There was a study done it was a meta-analysis of 25 studies, and then they recorded that the estimated rate of prenatal transmission was 5.8% among women that have only Hep C viremia but not co-infected with HIV. Now, that would actually increase up to 10.8% in those who are actually co-infected with HIV. And so that's where the importance of testing for HIV also at the beginning of the pregnancy, as well as Hep B and Hep C. Now, the use of injections, the use of maternal drugs used through injections, that several studies have actually shown that maternal injections of drug use will increase significantly the risk of Hep C transmission. The mechanism of how this happens, to be honest, is not clearly known, but it may actually increase infection of peripheral blood cells in persons who already have Hep C. And another one that is very important is the intrapartum exchange of fluids. Several factors have been identified that can actually enhance the risk of perinatal Hep C transmission at the time of delivery, including especially in those who have prolonged rupture of membranes, especially if it has been more than 6 hours, any obstetric procedures or intrapartum events that can result in infant exposure to maternal blood, like internal fetal monitoring or vaginal or perineal lacerations, can actually increase the risk. Now, it has not, and there's not enough studies that says that the mother to child Hep C transmission actually is associated with the mode of delivery, because there has always been the question: should these baby be delivered via C-section and not vaginal delivery? And so far, the studies have not shown any significant difference regarding the increased rate in transmission. Next slide, please. So, what happens, and this is kind of one of the most common questions that we get, not only from the mother, but also from that newborn, right? What's the impact of Hep C on pregnancy and the perinatal outcome for that baby? So, we know that there is an increased risk of some perinatal outcomes. For example, preterm delivery, low birth weight, and congenital anomalies. Now, we have to kind of be mindful that there is a lot of confounded with comorbid conditions, especially the substance use, the socioeconomic status. Most of the patients that will have a low socioeconomic status usually will not have prenatal care. And that is also can be associated with low birth weight, premature babies, and congenital anomalies. Here is when we tend to see more of those risk factors like the use of substance abuse or the use of IV drugs, were tend to be associated with congenital malformations as well. Now, in a person who is pregnant with and has Hep C and it's identified to have cirrhosis, we have identified that there is an increased risk of poor maternal outcomes that can lead to poor neonatal outcomes, and those goes from preeclampsia, the need of C-section, hemorrhagic complications, and even death on the mother side. With neonatal outcomes that kind of are secondary to those complications that the mom can have, like low birth weight, preterm delivery, neonatal death, respiratory distress, among other ones. Next slide, please. So, what are the interventions that currently we are doing to the mom in order to prevent vertical transmissions of Hep C? So, there are really no clear guideline of like these are the interventions that are going to be the best, right? Or these are the things that are going to let us actually prevent that baby to get Hep C. And I think we have discussed this in the past, where we've talked about what is going to be the importance of actually be able to treat pregnant women. And the goal is to get there, because if we're talking about perinatal Hep C and Hep C in children, we know that the great majority of kids who have Hep C have been actually infected during childbirth or during pregnancy, not compared to adults, which is usually more associated with risk behaviors, right? So the fact that we can at some point get to that goal where we can treat pregnant women would actually have a great impact on what we see in pediatric hepatitis C, because we will be talking about a significantly decrease on the amount or the number of cases that we have. Now, so far, and this is kind of where we talked about the use of direct acting antiviral therapy in pregnancy, there has been no large clinical trial so far that I know that can impact on that. We've talked about different discussions that have been going on, and probably Dr. Chastain can give us a little bit more update on that. But so far, they have been doing some small serial trials where they use sofosbuvir, and they are evaluating the safety and effectiveness of that of during pregnancy as well, right? When we talked about treating a pregnant woman, we're not only thinking about the mom, but we are as well thinking about the baby. So this is something that it will definitely change how we talked about hepatitis C in children once we're able to treat pregnant women. Now, things that we usually tend to do as doctors to avoid or prevent vertical transmission is try to use as much as we can the avoidance of placental contact over chorionic villi sample, especially in those moms that are infected. We usually try to recommend that not to do this sampling, not to do invasive procedures, even fetal monitoring. We don't use any internal fetal monitoring in order to avoid that. Now, during the intrapartum process and how we monitor those, we really want to make sure to avoid the prolonged rupture of membranes. We know that more than 6 hours of prolonged membranes that are ruptured have been increased to an increase in the possibility of transfer that. And so that's where it comes important. Now, we did talk about the mode of delivery. So far, there is no conclusive data that says a routine C-section should be actually done to prevent perinatal Hep C. And it's not going to be the recommendation regarding the mode of delivery of that baby. Next slide, please. So what about breastfeeding? And this is one of the most common questions that we get from the moms, or can I breastfeed my baby? And the answer is yes. Breastfeeding is safe every time on that baby, as long as we don't have any damage, crack, or bleeding nipples, because that's when there can be a transfer or increase of the contact of infection, right? So yes, but breastfeeding is safe for mothers with Hep C infection. So we are usually recommending for that baby to be breastfed. I know the concern is that am I going to infect that baby? But no, we tell them you can actually breastfeed. Next slide, please. And so we get to the point where the baby is here now. We know that, our hepatologists, infectious disease doctors, or even OBGYN, and that's kind of the goal. Focus now on treating the mom who is infected with Hep C. We want to make sure that that mom receives treatment as soon as possible, because we know that if she gets pregnant again, then we want to make sure that kid is not exposed, right? But then what happens with the child that now is born? So now we are recommending to test as soon as 2 months of age. And the first test can be between 2 and 6 months when they come to their well child care. Usually it's going to be NAT for Hep C or Hep C PCR RNA. And after that, if that is confirmed or that is positive, then it's considered that the child is infected. So we are going to continue monitor that child throughout the next 3 years until he comes to the age where we are able to offer treatment. Now, what happens if that child comes a little bit later, not during your well child care up to 4 or 6 months, but usually at 7. So between 7 and 17 months of those who have not been previously tested, we are recommending still using the Hep C PCR RNA, for Hep C. Now, if that child is older than 18 months or 18 months of age and has not been previously tested, we are going to recommend to get the Hep C antibody with a reflex to the PCR RNA. As usually, this is going to be confirmatory of if the kid is infected or it's not infected. And these are the new guidelines now approved by the CDC that Tennessee Department of Health has been actually following since almost 2019, if I'm correct. But we actually have been following these new guidelines. Next slide, please. So what happens? And this is a very common question because I've had pediatricians who call me, hey, this baby is 2 months old. We did the Hep C PCR RNA. It's positive. What do we do, right? What's the next step? And so we usually tell them that at that time, we're going to continue following child as we normally will do. He will continue with his regular well child care visits. He will continue with his vaccinations. We are going to provide education to the mom about the importance of actually getting vaccines for Hep B and Hep A as he goes through, 2, 4, 6, and then a year old. And so we are going to recommend to continue taking care of that baby as they would normally do. The only difference is that usually we will check yearly liver enzymes, AST and ALT in that baby to make sure that the numbers are staying stable and no concern. But there should be no rechecking of or not continuous monitoring of viral loads every 2 months or so. And that's one of the most common questions. Do I need to repeat the viral load? Do I need? No. We tell them you get one PCR RNA positive We know he's infected. We will continue, and once he gets closer to 3 years old, we will repeat labs. We'll get a genotype, but we will continue monitoring that kid as it would be a normal, healthy baby. Next slide, please. So, and this is where we talked about, right? We usually will do at the initial diagnosis. We recommend obtaining an ALT, AST, a CMP, and a total bilirubin. We want to make sure those numbers looked okay. We want to make sure we have a baseline as we're going to continue following every year. So for the first 3 years of his life, these baby will obtain yearly labs. And that's going to be the only difference from what we usually do in a well child care appointment, where most of the time we're going over development milestones, where we're going vaccinations, where we're checking lead levels. So this will be the only difference that we will tend to see in the care of that baby. Next slide, please. So, and this is one of the most important slides that I can actually show you. And this is just kind of saying what's the importance of the vaccinations, right? We are not going to give any extra doses of any of these vaccines, but we're going to make sure that that baby especially receives Hep B and Hep A viruses. We want to prevent that kid to get any other infection from any other hepatitis virus, because we know that that can affect the liver. And so we want to make sure this kid gets all his vaccinations possible. We even recommend now that RSV has been included, and those kids who actually are recommended to get RSV vaccines to actually go ahead and do it. So we're not gonna limit, we're not going to change anything on the vaccination, on the vaccine recommendation that the CDC does. Also, it's important to know that we don't have a Hep C vaccine. And so that is why it's so important for us to promote the use of Hep B and Hep A vaccines in all children, but especially in those who have Hep C. Next slide, please. So, as I was saying, what happens next, right? We are following this kid. We are checking his, we're checking his levels every year, his liver enzymes every year. We're vaccinating him. So by the time that they are getting close to age 3, we are going to confirm if this baby or this patient still has chronic Hep C, as we also know that there is the possibility of spontaneous clearance. So when the time comes and that child is getting close to 3 years of age, we are going to retest with a Hep C PCR RNA right before beginning the treatment. A lot of the time, the new way that labs are being drawn, you are actually getting a reflex to get a genotype. And that's when usually we'll get the genotype as well. Remember, we will get other labs when the time comes when we actually confirm that he has chronic Hep C, where you're going to get an HIV level as well as a Hep B surface antigen and antibody. Next slide, please. And so this is kind of like the one of the most common questions, the serial testing, right? Really, it's not always required. There are some exceptions to the case where we know that if we see, okay, a kid who probably had elevated ALT or AST, and then suddenly we see that they are going back to normal and it has been lasted for more than a year, and you're suspecting that there may be like a spontaneous clearance, absolutely. We can retest to see if that virus has cleared. When treatment is being considered, and that goes with when we're getting close to the age of 3, because we really want to know if that child still has an active Hep C infection or not, as that's going to be very important in order for us to confirm and then start treatment as soon as possible. Next slide, please. And of course, we kind of have tried to push the message of who do we treat, right? Any children that is 3 years of age or above with a confirmed Hep C infection, we want to treat as soon as possible. We don't want to delay treatment. We want to make sure that our pediatricians, our healthcare providers in the area feel comfortable. So we're pushing more and more and more that we are making it so simplified. So people start getting treatment as soon as possible. And this will be the case when they are 3. Next slide, please. And we're going to go and evaluate some of the factors for treatment. Of course, we talked about the Hep C viral load, the Hep C genotype, as we have discussed in the previous sessions, we do have medications now that cover. And of course, this is not the goal to talk about those medications, but we have polygenotype medications that will cover for these ones. We are going to get Hep B serologist. The age and the weight of the patient is going to be important regarding choosing the dose, especially in the pediatric population. If there is any drug interactions, most of the time our 3 years old are not taking a lot of medications, but it's important to know that we need to assess if they're using any seizure medications, heartburn, any other kind of medication that interact. The insurance formulary, what's the preferred drug in that case, according to their insurance. And of course, what's the patient's preference, right? Because that's going to have an important role into making a decision as to what's the right treatment for that patient. Next slide, please. And this is just a reminder. We're not going to go into detail of that because we know we'll have more sessions, but these are reminders about the different options of medications that we have and the length of treatment therapy that we do have. We have capavir prevents severe with any genotype. We have sofosbuvir and velpatasvir with any genotype, and lenacapavir and sofosbuvir with genotypes 1, 4, 5, or 6. And so this is just kind of a reminder of what are options available for children. We know like these are, we know commercial names, Harboni, Epclusa, and Maverick are the ones that we are going to be using on our kids. Next slide, please. And the therapy goal. And this is kind of another important question that we get a lot. So once we treat, how we know he's cured, or how do we know if that child is cured? So the goal, of course, is to eradicate Hep C RNA. And this is predicted by the attainment of a sustained virological response, defines as undetectable levels of RNA at 12 weeks following the completion of therapy. So in the cases where the treatment therapy lasts 8 weeks, we're checking at the 12-week mark after they have finished that, which is going to be the 20 weeks. And in those who last 12 weeks, we're going to check at the 24-week to make sure that there's no detectable levels. Next slide, please. And while they're actually getting, and this is something that we talked a lot. We talked to the adult patients, we talked to pregnant women about it. We talked about the children's, right? Because reinfection, it's possible. And that's why the CDC and every other medical institution or organizations recommend checking every pregnancy, because reinfection is possible. Because we know that that Hep C antibody will always be positive, and that the test of choice for that woman or for that child who has been infected with Hep C is going to be a Hep C RNA PCR. Treatment does not prevent reinfections. We don't have vaccines either, because some parents have told me, no, he has his hepatitis vaccines. So I explained them that no, the hepatitis vaccines that we have, and I think that's where we are giving more and more educations, are for Hep B and Hep A. But we don't have one for Hep C, and we know that the treatment does not prevent reinfection. So it's very important to educate the parents, to educate all pregnant women about the goal of treatment is to make sure we cure, but reinfection is still possible. Next slide, please. And education. You're going to see that I love this slide, and I always put in our talks because it does make a difference. We want to make sure we provide, and when we sit down with our patients and talk about Hep C and talk about the importance of treatment and diagnosis, we want to also educate them. A lot of the time they're putting a big stigma on, oh, my child has Hep C, I don't want anyone to know it, I don't want to do this, I don't want, no. That child deserves to have a normal childhood. That child deserves to go anywhere he wants and enjoy all the activities that he wants, right? And the parents want to share with. We tell them he can go to school, he can go to daycare, that there is a significant, very low risk that he can infect anyone, right? We do tell them you have to follow universal precautions. as you would do with any other child, especially when the use of toothbrushes, razors, nail clippers, or the use of gloves and bleach to clean blood, correct? But we are not limiting. We are trying to educate more and more. We know that this is something that has a cure. We have been advocating to treat more and more every day. And that's why we push for that child to have as normal childhood as possible. And education. It does bring a change when we let the parents know that this should not be a stigma, that they can actually be treated. And we actually even talk to the parents about the need for them to be treated as well. So we try to do not only the education for the child, but we try also to get the parents engaged as well, especially the moms, as they are or will continue to have babies in those cases. Next slide, please. Any questions so far of what we talked before we had to move on to the cases? And I don't know if Dr. Chastain is here, but I know he had some updates last time he talked about the use of medication in pregnant women, which I would love to hear a little bit about that.
Sure, I can jump in here. So thanks, first of all, Liggy, for a great overview. Really great from epidemiology to screening and also the flow of care. So it's fantastic. And just definitely want to encourage folks to put your questions in the chat, or I'll be brief and then people can pop on. I want to highlight we very likely will focus on this as a topic for an upcoming echo session and go through the data, what we know, what we don't know. But I think the big takeaway thus far is that we have one small study that looked at levodosphere, sofosbuvir, trade name Harvoni, and a small number of women who are pregnant with excellent outcomes, high cure rates, and no adverse effects on pregnancy. There's a subsequent trial that is ongoing, nicknamed the STORK trial, that has been rolling for sofosbuvir velpatasvir for several years, but has been a slow enrollment for a variety of reasons. Actually, Vanderbilt University Medical Center has recently come on board as a clinical site and either is now accepting patients or will be accepting referrals and patients within the next few days to weeks. And that is a trial focused on sofosbuvir velpatasvir for a pregnant woman, predominantly treatment initiation during second or third trimester, and then monitoring both maternal as well as infant outcomes. All the preliminary data from both that trial and others is that there does not appear to be an adverse effect. There's also some real world case series where women have been treated either based on medical decision making involving the patient and provider, or a person became pregnant while on therapy and outcomes were subsequently monitored. And essentially, there's no signal or reports about negative impacts on either pregnancy outcomes, maternal outcomes, or infant outcomes. That led to guideline updates to essentially suggest that while treatment is not specifically labeled, for the medications, for the FDA label, it is reasonable for a provider and a patient to consider treatment during pregnancy on a case-by-case basis. And that has led to certain sites, Northwestern and University of Chicago, as well as Washington University St. Louis, and as several other small programs, to actually starting to offer treatment on a relatively routine basis with intensive medical decision making and supportive care. That's kind of the lay of the land where it is right now. There is a clinical trial with the IMPACT group that, in the theory, will assess glecaprevir perbrentasvir, or trade name Maverit, in pregnant women also in the future. But that trial has been proposed but has not initiated to my knowledge. So I think that's the quick 3 to 4 minute summary about where we're at. But I think one of our goals in an upcoming echo session is to actually fully address that, show you on the slide, show you the study, show you the data about where things are at. And hopefully by that time, we'll actually have a little bit more granular information about the STORK trial and referral opportunities for those of you who might be working in different areas of the state.
And as we have mentioned, that would be a game changer for the pediatric world. The fact that we could actually prevent that perinatal transmission would definitely make an impact. As we have shown you the numbers, between 5 and 12% of those kids actually will get Hep C. And of course, most of our children between ages